We have today fellows from Pakistan, Lebanon, Poland, Canada, Singapore, US, and what is R? Who is R? Who is this R? I don't know.
I think it's
Rima.
Dr. Rima.
Maybe Rima?
Rima, hello, yes.
Rima. So, okay, Rima, hi Rima. So France,
Hi,
also
hi.
France.
So from all the world, around the
Yeah.
world.
Yeah, no, unfortunately, when we run these lessons, usually we do this at 7 a.m. or 8 a.m. in the US. In the other part of the world, the day is really in the middle part of it. So who is dealing with cat lab things is a little bit busy. So I think Sandeep would like to join us. Probably he will join us a little bit later. For Bharat, for you it's easier. In Singapore, it's night, but it's 8 p.m.
Yeah, I'm in Japan at the moment, actually. So it's 1 hour ahead.
Okay.
Now it's 9 o'clock. Yes.
Okay. So we also have one of our Italian fellows, Filippo. Welcome.
Hi to everyone.
So I think we can start. Again, I'm really honored to have a Professor Akiko Mehara today with us in the DCB Academy. Professor Mehara graduated at Yamaguchi University in Japan, then had some experience in Tokyo, and more recently joined the US. And currently Professor Mehara, which is a world-renowned cardiologist, is affiliated at Columbia University College of Physicians in New York, and is the Director of Intravascular Imaging Core Laboratory at CRF. Professor Mehara is Professor of Medicine at Columbia University. So this is just a small part of the prominence and importance of Professor Mehara in our field in terms of scientific relevance. So Professor Mehara, thanks a lot for joining us for this lesson. Sarah, do you want to present today's lesson?
Yes, thank you very much, Prof. Could you hear me well? Because my voice was
not clearly, Sarah. We cannot hear you clearly. You have to adjust this problem.
Yes. Now, how about now?
Now clearly. Thank you. Thank you.
Perfect.
It's fine.
Good morning, good afternoon, everyone. It's a great pleasure to introduce our guest speaker today, Prof. Akiko Mehara, who will present us a lesson about imaging of coronary calcified nodules. Dr. Mehara, thank you very much for joining us here today. It's a great pleasure and privilege to have you. Please.
Okay, can you see my slide?
Not yet. Yeah, now we
Yeah.
can see it. Yeah.
Okay, so let's start. I'm going to talk about my favorite topic about calcified nodule. Okay. So let me start this very typical case. This is a patient who is old and a bunch of the risk factor. And I couldn't show the movie today, but this is very calcified coronary artery and patient presenting the non-STEMI. So whenever you see this type of the case, you should recognize the underlying plaque is calcified nodule. And this is OCT picture. At the site of the stenosis, you see the irregular surface and some thrombus. And actually, this is a calcified nodule, and sometimes difficult to differentiate compared to the red cell thrombus. That's I'm going to talk more. But what is important is you go proximally or distally, you see the very circumferential calcium almost everywhere. So those are the very typical pattern which you can see in the calcified nodule. So the calcified nodule appear in the severe calcified region. Let me step back. This is a pathological picture. So the calcified nodule is really the accumulation of small calcium fragments. You see this picture? This each red star indicating the small calcium fragments. So I see the small calcium fragments here, small calcium here, small calcium here, small calcium here. So each individual calcium is actually quite small, but they are accumulating together. And in between, you see the fibrillin. Then they are, because coming together, whenever we see by imaging, you see like the chunk, like the mass amount of the calcium. But importantly, we have to remember the calcified nodule is really the accumulation of small calcium fragments. And knowing this, if you look into the OCT picture and more bigger picture, you can recognize inside of the calcified nodule is really small calcium fragments. Because when you diagnose the calcium by OCT, the most important feature is you have to see the very clear interface. So that's the definition of the calcium. So if you look into the very inside, you can see the small calcium fragments here, and I see the small calcium fragments here and here too. So we are really looking at the same pattern which shown by the pathologist. And this is not a big one stone, it's really small fragments. And this is a paper to compare the pathology versus OCT findings, and they including the bunch of the calcified plaque, but calcified nodule is only 3. But all of the 3 cases was exactly same pattern which I showed before. You see the calcium, protruding calcium, and there is a strong attenuation. And in adjacent segment, you see the very severe calcium. So this is a very typical pattern of the calcified nodule by OCT. And then I was asked many times why you see such an attenuation. Is the reason is two. Number one is because I showed before, inside of the calcified nodule have the fibrillin together, that's making the attenuation. And second, I think because of the calcium fragments, even though the OCT reflect with the calcium and then making the individual calcium, but there is so many different calcium and then making the scattering, and then I do think the losing the power. That is the reason we see the very strong attenuation by the calcified nodule. And this is IBUS paper to compare the pathology versus IBUS, how it looks like the calcified nodule. And in this paper, we show whenever you see the calcium is protruding to the lumen or surface of the calcium is such as irregular, those really the future of the calcified nodule by IBUS, which is quite different compared to this type of the dense calcium plaque. And this is a paper from Japan. It's quite interesting. They do the OCT as well as a near-infrared spectroscopy, which can evaluate the distribution of the lipid. So the all patient was acute MI, either non-STEMI or STEMI, and you see the very typical appearance of the calcified nodule by angio. They took the picture by OCT and IBUS, and importantly in this picture, the OCT picture looks similar to what we see before, but by IBUS, you see the yellow at the site of the calcified nodule. And altogether, they show the amount of the yellow in the calcified nodule is actually not so low compared to, for example, the plaque erosion cases. So this is also shown by the pathologist. Inside of the calcified nodule, not only the fibrillin, sometimes we see the intraplaque hemorrhage or necrotic core. That's the reason sometimes we see the yellow or lipid composition at the site of the calcified nodule together. Next one is a paper. We compare with the angiographic appearance and OCT calcified nodule. And in this specific study, we including only the OCT calcium maximum arc is more than 180. So this is some bias cohort. But including those, whenever you see this type of radiolucent appearance by angio, 95% of the time that was calcified nodule. However, if you don't see the radiolucent mass, 35% of the time, it was still calcified nodule. So angiographic appearance, this type of the radiolucent is very good positive predictive value to predict the calcified nodule. And importantly in this paper, this is what I wanted to emphasize. Whenever you see the calcified nodule by angio, many times we feel almost this is like the occluded artery. That's what we feel. But this is angiographic appearance, so we measure the QCA in terms of the minimum lumen diameter. But when we look into the OCT, most of the time, actually the lumen was very eclipse shape. And then not only here, but also there is a space behind the calcified nodule. And then lumen is actually not so small, even though angiographically looks very severe. So when we compare the MLD versus MLD angio versus OCT, we see the much more discrepancy when you see the radiolucent mass. So because I'm going to explain how bad the outcome of the calcified nodule if you treat it. So it is very important before treating the calcified nodule, we have to confirm the ischemia because many times angiographically looks very, very bad. We overestimating the stenosis. The next paper is comparison between the CT and OCT in terms of the diagnosis of the calcified nodule. So those are the individual picture comparing the CT versus OCT. And in this paper, it's very consistent. What they show is the case which having the calcified nodule is a lot of calcium. So they show some cutoff value, but I think what is important, whenever you see the chunk of the calcium by CT, you should expect the calcified nodule inside of the coronary artery. And then let's make it clear, what is the patient pattern or morphological pattern, anatomical pattern to predict the calcified nodule altogether? This is a paper we published a long time ago, including about 900 patients. And then by OCT, we diagnosed the calcified nodule at the culprit region versus no calcified nodule. And when we compare the patient pattern is older and more likely hemodialysis compared to without. And angiographically, at the site of the calcified nodule, there is much more hinge motion compared to without. And also the mean arc of the calcium by OCT is much larger compared to without. So if we say by patient or anatomy, what looks like the calcified nodule region is patient is old and more likely chronic kidney disease, and also angiographically a lot of hinge motion, or more likely right coronary artery. And if you do the IVUS OCT or CT, you see much more calcium, underlying calcium, compared to without calcified nodule. Those are the pattern which we should recognize at the lesion or patient who had calcified nodule. And then we ask, what is the prevalence of the calcified nodule? Whenever we talk the underlying plaque in the ACS patient, many times we state calcified nodule is only 3 to 5% of the entire ACS. That is really true. However, if you do the denominator as the only region which having the large calcium, the prevalence is quite high. So this is based on the OCT, we separate in the region which having the maximum calcium arc is more than 270, which is very large calcium. Although the prevalence such region is not so high, but if you include only those regions, the prevalence of the calcified nodule in the culprit region is already 1/3 of the cohort. And if including only the ACS patient, this is about 40%. So I think it is important, even the ACS, MI patient, you see the patient is old, angiographically a lot of calcium, you should expect underlying plaque is calcified nodule is almost 40%. And this is a new data which we are going to publish soon. And we recognize when we look into the instant cases, actually we see much more calcified nodule at the stent edge compared to the de novo segment. And then we analyze about 1,000 cases and ask very simple question. Is this calcified nodule is more prevalent in the stent edge compared to non-stent edge? And the answer was yes. And the prevalence of the calcified nodule at the stent edge is actually 15%, which is much higher. And then interestingly, we see the calcified nodule at the stent edge, even we never ever seen in the de novo calcified nodule, such as diagonal branch or distal circumflex. So seems to be putting the stent and then making the big hinge motion at the stent edge may generate calcified nodule in the future. Although this paper, we didn't have the prospective data, but still that's evidence which we may have to consider putting the stent at the calcified plaque may causing the future calcified nodule development. And when we look into the OCT, there is a different pattern of the calcified nodule. This is a two different case. You see the exact same pattern angiographic radiolucent here and here. But when we look into the OCT, very different. One is eruptive. You see the surface is irregular and fibrin together. The other one is you see the calcified nodule strong attenuation and protruding calcium. However, the surface is nice fibrous cap. So those we consider eruptive but not eruptive. And when we look into the calcified nodule by comparing the ACS versus stable angina and ACS patient having the calcified nodule more likely contain the thrombus. So I think eruptive versus non eruptive is sometimes difficult, typically by IBUS. But if the patient presenting the ACS, we should consider most likely those are the eruptive calcified nodule. Additionally, we ask, what is the natural cause of the calcified nodule? Is this really coming from the calcified plaque? To answer that question, this is also the new data. It's going to be published soon. We including the 372 lesion, which having the 2 times OCT. This is very biased cohort. In some reason, 2 times OCT. And all those cases, we picking up the non-treated de novo calcified plaque, no calcified nodule. And then we check the second time OCT, how often we see the new development of the calcified nodule at the site of the non-calcified nodule calcium. So this is a case example. You see the calcified plaque, no nodule, and patient having the event at the later, and we see the new development of the calcified nodule here. And at the time, it was not obstructive, no treatment, but later on, you see the radiolucent is larger, and that's going to be treated. So the prevalence of the new developed calcified nodule was 7%. But importantly, in this paper, this is a biased cohort. So I think the overall entire cohort, probably the prevalence of the new calcified nodule development should be less than 7%. But this is a confirmation calcified nodule is really coming from the calcified plaque. And we ask, what is the important predictor to predict future calcified nodule development? It's quite consistent compared to the already calcified nodule present lesion, meaning like the more calcium or higher hinge motion, those calcium is more likely calcified nodule in the future. Additionally, we say this is calcium with attenuation. What is meaning? Whenever the calcium is developing, it's not like the yes or no answer, meaning start from the necrotic core, and in some point you see the calcium, but still there is a necrotic core together, like the case which I show in the with the Nias ibis. So I think whenever you see the lipidic plaque together with the calcium, those are the more likely causing the future calcified nodule development. And this is a natural history from the CLIMATE trial. You see that when the patient having the non-treated eruptive calcified nodule, their poor outcome compared to without. And then let's talking the treatment aspect. So this is again, I'm going to show the eruptive versus non-eruptive. And now I showed how it looks like the post-stent. And the eruptive calcified nodule is typically those calcified nodule is redistributing into the artery, and then we see typically nice stent expansion. On the other hand, non-eruptive calcified nodule, we are stretching the non-calcified nodule side. And although most of the time we can see the good expansion by stretching the non-calcified nodule side, but doesn't change a lot in terms of the calcified nodule itself. And this is a case example at Columbia. You see the calcified nodule in the mid-right coronary as well as distal. You see the nice calcified nodule. And this case, we did the obituary, and then we did the stent, and you see the nice expansion. However, the patient having the LAD lesion in the staged procedure and coming back 5 weeks later, and we took the angio in the right, and we surprised almost same place. We see the radiolucent, and we did the OCT, and you see the calcified nodule. But honestly, I couldn't diagnose for sure this is calcified nodule. But to me, it seems to be the red cell thrombus. And then we are not very sure, and we opened the IVUS, and we confirmed this is actually really the calcified nodule. And this time, we put the Megatron, and we pushing the well on the calcified plaque. And then later on, patient did well, but coming back 5 weeks later. So what is meaning? This is really the phenomenon of the calcified nodule, because each calcified nodule is very small fragments. They can reprotruding through the stent. Because remember, how much coverage of the stent slot is only like 15 or 80% of the surface area. So actually stent slot is not covering everywhere. So in between the stent slot, the calcified nodule can be protruding through the stent. That is why we see this type of phenomenon. Okay. So I think finally this is the data from the St. Francis Hospital. We analyzed almost like the 10,000 cases. And one of my fellow, he checked everything at the end. Out of all 4,000 patients, he checked all OCT one by one. And finally, he found 284 calcified nodules. And of those, about half was eruptive and half was non-eruptive. And then the distribution of those calcified nodules is consistent with the prior study, meaning the right coronary artery is the most frequent, but the eruptive calcified nodule is more frequent compared to the non-eruptive calcified nodule at the mid-right coronary artery. And this is the data which I explained, meaning when we compare before and after the stenting, how it looks like the calcified nodule, and my fellow, he analyzed the circumference of the calcified nodule before and after. And if that is eruptive calcified nodule, the circumference is longer compared to before. That's indicating redistribution of the calcified nodule. That's never happened in the non-eruptive. That's quite significant. And then we ask, what is a predictor of the stent expansion when we treating the calcified nodule? Number one, good predictor is actually eruptive calcified nodule compared to the non-eruptive. So eruptive calcified nodule having the better stent expansion compared to non-eruptive. That's number one. But additionally, there is a bunch of the important aspects. So I'm going to explain one by one. The circumference calcified nodule, meaning how big the calcified nodule. If big calcified nodule, less expansion. Number two, surrounding calcium arc, meaning many times we see the non-calcified nodule calcium at the same place. If we have more calcium in non-calcified nodule site, poor expansion. That's actually very important. And the other aspect is really the indication of the stent expansion, regular calcium, meaning if the calcium thickness is thick, more likely poor expansion. And also the negative remodeling together, that's poor expansion. Those are the important aspects. So whenever we talk the expansion of the calcified nodule, always we just talk the calcified nodule. But what is important is you have to look for the other things. If other calcium together, poor. If negative remodeling is poor. If you have big calcified nodule compared to small calcium is poor. Those are the important aspects to predict the poor stent expansion. Finally, this is supplies or kind of paradox. If we have the calcified, eruptive calcified nodule, they are good expansion, but actually the outcome is opposite. Eruptive calcified nodule is more event compared to non-eruptive calcified nodule. And really the reason was they are reprotruding through the stent. And then we ask, what is the important predictor of the target lesion failure in those calcified nodule region? Eruptive is worse compared to non-eruptive, but additionally, there is other important factor. Start with the small stent area, their poor outcome, and the size of the calcified nodule is large, their poor outcome, or at the site of the calcified nodule, large hinge movement, their poor outcome. So when we consider, I'm going to treat the calcified nodule, what type of the calcified nodule, we have multiple predictor. Hinge motion, large calcified nodule, small stent area, eruptive compared non-eruptive, those are the indicating the poor outcome. Okay, I think to summarize, the calcified nodule appears protruding calcium with irregular surface by IBUS, and moderate amount of the lipid composition by NIAS if you do. And calcified nodule is present in the vessel with severe calcium in the old patient. So actually that can be predictable based on the patient appearance. And also, OCT can differentiate eruptive versus non-eruptive, but sometimes it's very difficult. In such, most likely, if the patient presenting the ACS, that's probably the eruptive, and the eruptive is poor outcome compared to non-eruptive. But altogether, what is important, you have to look at the entire region subset to confirm which calcified nodule is poor outcome. And finally, before treating, we really have to confirm the calcified nodule is really causing the ischemia, because many times we are overestimating the stenosis. Thank you so much.
Thank you, Professor Mehara. Thank you, Akiko, for this state-of-the-art lesson on calcified nodule. We learned a lot. I like the way you prepare the lesson from pathophysiology, trying to understand a little bit more on the causes for calcified nodules, and then to the two bigger types of calcified nodules that we have. I have a question for you. Probably fellows have a lot of questions, but this question is in my mind since a little bit. So eruptive calcified nodule is easier to treat than non-eruptive, okay? Non-eruptive is associated to more stent under expansion. However, prognostically, eruptive calcified nodule, either you treat it or you don't treat it, is associated with impaired outcome. So you clearly said that we have to treat calcified nodule only if it's leading to ischemia, not if it's just a by chance finding by intravascular imaging or by angiography. But my question is, how should we treat calcified nodules, meaning the eruptive ones, which is associated, as we said, with impaired outcome? Is there any information if we should use any atherectomy for eruptive calcified nodules associated with, more prognostically favorable outcome? Or we don't have yet this data?
Yeah, we don't have that data yet. Really, we don't. I think we have to look for, but I think actually atherectomy, like, as I said, what type of the calcified nodule is bad? Big calcified nodule, right? So I think ablation and then decreasing the calcified nodule seems to be theoretically reasonable. But when we look into the atherectomy before and after, how much we are ablating is actually not too much. So I think the other things which is really important, like the adaptive calcified nodule is really the active like the lesion. So how to stabilize converting the non-eruptive, meaning the having the cap, could be more important, or could be also important, not more. In such, I think the coating balloon, and then like at least we have to open up. So when we open up, you need some injury in the lesion. So we have to inhibit the neointimal pressure. But at the same time, you may make like the stabilization of the eruptive. So to me, like make it larger, and the coating balance to me seems to be as reasonable as well, but nobody proved. And as I show, when we see the stent inside of the calcified nodule, or like even no calcified nodule to start with, we see more calcified nodule at the stent edge. I don't know how stent making better compared without stent, because stent making the poor, like the coronary artery, like the mobility. So I think. So like also like when you put the long stent, you have more fracture, and calcified nodule seems to be like we are making the fracture of the calcium itself. So I think like the probably stabilization important, and then non-stent technique could be more important than stent technique. That's, I think we have to investigate more prospective way in the future.
Yeah, there is a good basis for other therapies like DCB. Of course, we are happy to hear this from you. And we should start thinking at a trial in this setting. Yeah. Hi, Sandeep.
Hi, Akiko. Thank you so much. I mean, every time you talk, I hear you talk, I always learn something new. And if you're a speaker, I never miss the talk. I never miss the talk or the session. Thank you so much. I have a question, like expanding on Bernardo's question about these eruptive and non-eruptive. Have they studied the histological difference between these two? Why is it more aggressive, like a cancer? Is it to do with the cell infiltrates behind the intima? What makes it more dangerous? Any idea on
Yeah,
that?
yeah, I think there is a very good paper in the JACC, which was the first author is his last name is Tori, and senior author was Reni Bermani in JACC, I think 2021. So those papers clearly describe how it looks like the eruptive calcified nodule versus non-eruptive. And actually what they call the non-eruptive is healed calcified nodule. So pathologically, it seems to be this is all like imagination by the pathologist because they don't have the consecutive pathology. But based on what they describe, is really the eruptive one is really happened recently, and they still like the break of the fibrous cap, and then still there is a fibrin together. But once break of the fibrous cap, any kind of coronary artery getting healed, and then you see the fibrous cap on top, and then that's eruptive one is inside of the plaque. But and then in terms of the hemorrhage or like the necrotic core is more often in the eruptive compared to the non-eruptive. So that's I think it's exactly what we discussed today.
It's more active.
Yeah, that's what I think. Yes.
And one last question is the you said about the iatrogenic calcified nodule, the stent edge, which you've seen in your study. Does this mean that when we do this OCT and things, so especially calcified lesions, we have to go from healthy to healthy, especially if you're going for a stent, because you don't want to land the stent in a calcified, although it may not be occluding the lumen or it may not be stenosis, but you have to avoid stenting at the calcium edge. Am I right?
Yeah, in theory, that's true. But you're just thinking about how looks like the patient which having the lesion with calcium, and it's almost impossible to go to the normal to normal. So I think this is always the like the dilemma. But I think in theory, answer is yes. I do think so. So I think really we have to ask ourselves, I'm going to treat, should I treat or not? And then if treat, go to normal is better, or non-calcified nodule to non-calcified nodule is better. Is it possible? So all those things we have to consider all together. And then should we treat only here as a stent, either is drug coating balloon or non-treat? Those all together we really have to think about. But importantly, this is all like the event cases. So I think we are exaggerating the number a little bit. So I think like the prospectively, the number should be less. So altogether, I think, yeah, I don't have the clear answer, but I think, that's what I said, yes.
Thank you so much. Thank you.
Yeah, no, because the question is, this is something that is not clear, I agree. So is the calcified nodule which appears during follow-up at the edge of the stent related to the fact that the stent did finish on a calcified nodule, or the fact that the edge of the stent is associated to the occurrence of new calcified nodule?
Sure, yeah, that's a good question. I think our data is cross-sectional, it's not follow-up. So we just look into the one time point and then we ask how often. But I think, as I said, like I never seen the calcified nodule in the de novo calcified nodule super distal circumflex or like the diagonal bulge. I never ever seen the de novo. But when you have the long stent into the circumflex and distal edge, I see the calcified nodule. So distribution is very different compared to the regular calcified nodule. So that's really supportive data that's probably newly developed. And then actually when we still this paper is ongoing, and then during the revision, reviewer asked exactly what you said, and then they ask us to go back to the baseline OCT, and out of 900, we have about like the 80 cases having the OCT picture before stenting or right after the stenting, and majority was not present. So even though the small cohort, we see those edge calcified nodules actually newly developed based on the stenting.
But do you think that there was the edge dissection?
No edge dissection. It's actually nicely done, just calcium, and then newly developed. At least based on like the 80 cases, which we had the baseline.
Okay.
Yeah, we should study, we know that the effect of stenting, especially long stenting on a radial wall strain, So we should study also the effect of stenting on radial wall strain. Maybe there is some effect of the stent itself on the edge to cause in a patient which is prone of having calcified nodule to be a trigger on having new calcified nodules at the edge of the stent. This is very interesting. Yeah, very nice. So it's a field in movement, you know. It's a very recent acquisition in interventional cardiology, which has a very strong impact on the prognosis, and still we don't know which is the best treatment. If to do PCI, if to do CABG, or if to use atherectomy. So really, in the next few years, hopefully, we'll shed light on several aspects of this disease.
Yeah, I really think we need a prospective study based on some hypothesis generate. Yeah.
Yeah, we should do that. Yeah.
I have one question.
Marcus, please.
Yeah, thank you. Sometimes we are dealing with the calcified arteries and we are doing performing IVUS, and on IVUS there is a 180-degree arc calcium, and we are treating this calcium. After stenting, we are achieving the minimum stent area according to distal reference vessel diameter. But we will be short of that stent expansion, even short of less than 90%. So what about this? Because still stent is very well expanded, but at the certain point due to calcium, there is a slightly step down. And according when we are measuring the stent expansion according to the distal reference vessel, so we are coming very short of the near about 90%. So what will do? Should we become more aggressive at this stage, or just leave this step, or just continue?
I think that scenario, if I do, I prefer leave it alone, because once you start chasing the stent edge calcium, okay expansion compared to the distal reference, but distal is small, so actual absolute area is not super big. That's you are saying, right? And once you start chasing those, you make more issue, meaning like you make the dissection and more long stent.
Right.
It's actually, to me, it's even worse. So I think, again, you really have to ask yourself, should I stent such distal small segment or not? That's number one important question. And if you don't have edge dissection and okay expansion, I think don't chasing too much, because again, you make more issue, right? And I think I said, we see the more calcified nodule at the stent edge, but I think actually what is the worst plaque pattern which causing the future stenosis is still lipidic plaque. So if you have the lipid, you should extend to cover the lipid. I think that's true. But how much impact prospectively the calcified plaque? It's true, but I think overall prevalence of the calcified nodule is too much. So I don't think chasing such segment based on our current retrospective data is probably overreacting. That's my opinion.
Okay,
Yeah.
thank you.
All right. Thanks a lot, Akiko, for this wonderful lesson. Also because it was done before TCT, so I can only imagine how can you be engaged with staff and all of that. I hope to see you in a few days in Washington, actually.
Yeah, thank you so much.
Yeah.
Thank you. Thank you.
Thanks
Thank you,
a lot.
Akiko. Thank you so much.
Thank you very much.
Thank you.
Thanks a lot.
for having
Thank
us.
you.
Thank you.
Have a nice day.
Thank
You
you.
too. Bye.
Thank you.
Bye.